of acute limb ischemia occur as a result of thrombosis. Another possible cause of acute peripheral vascular disease is an embolism. Now, an embolism, remember, is anything that is going to travel around in the blood. And in the case of peripheral vascular disease, most emboli will originate in the left atria as a result of atrial fibrillation. Maybe 30% of cases are caused as a result of embolism. Now, we've looked at the etiology of the atheroma in the blood vessels. Does it make sense that if the patient has got these risk factors for the leg arteries, then these risk factors can affect the heart arteries and indeed the cerebral arteries as well? In other words, there's an increased risk that these patients are going to be arteriopathic systemically, that other arteries could also be atheromatous. So what we should do with all of these patients is assess them for these risk factors. Assess them for the risk factors of coronary heart disease, which, as we've seen, are very similar to the risk factors for peripheral ischemic disease. And when we assess them for these risk factors, we may find that they have some risk factors which have not been recognised before, which can then be modified. For example, it's quite common that type 2 diabetes mellitus goes unrecognised, sometimes for many years. The patient could be chronically hyperglycemic for many years. And all the time, damage is being done to the blood vessels as a result of the unmanaged diabetes mellitus. Another condition which is often asymptomatic for long periods of time is hypertension. Patients can be hypertensive for many years and not have any noticeable symptoms, or certainly not report it, so the condition will not be managed. Whereas if the condition is recognised, maybe it can be managed with one diuretic tablet a day. It's often straightforward to manage some forms of essential hypertension. So we must look for these factors so that we can modify them. This will prevent development of the peripheral vascular disease, hopefully. But probably more important is it'll prevent the development of coronary heart disease and reduce the risks of the patient dying of an acute coronary arterial event. So here's one of these sayings. It's trustworthy and worthy of acceptance. The next area I want to look at are the clinical features of peripheral vascular disease, and we're thinking here primarily about the clinical features of the chronic form of the disease. And the first feature I want to talk about is called claudication. Now, claudication refers to the cramping type pains that these patients can get in their muscles. And where the pain is an indication of the level of pathology. So for example, if there's pathology in the aorta or in the iliac or femoral arteries, you can actually get claudication that goes right up into the buttock. If there's pathology in the femoral artery, lower down, or higher up indeed, you can get claudication in the thigh muscle. It depends on the level of pathology. If the pathology is lower down, then the pain will occur in the calf muscle. And it is the pain that occurs as a result of ischemia, and the ischemia causes anaerobic metabolism, which causes the accumulation of lactic acid in the muscle. Now let's look at a patient now who is complaining of claudication in his calf muscle. I've got a pain in my calf muscle now, but when I was walking up there further along, I'd just started walking. I didn't have any pain. The reason I didn't have any pain was that although the blood supply to my calf muscles is limited, it was enough. There was enough oxygen getting to my calf muscles to allow aerobic metabolism to carry on. But then as I carried on walking and I put a greater exercise demand on my calf muscles, and therefore a greater oxygen demand, my calf muscles ran out of oxygen and I started limping. I was getting pain. I was getting pain because the muscles had to change from aerobic metabolism to anaerobic metabolism. And in anaerobic metabolism, you get the progressive accumulation of lactic acid. Lactic acid in the muscle causes the pain that we refer to as cramp. So to begin with, I was not limping. Later on, I was limping. We call this type of pain intermittent claudication. Now, Claudius was a Roman emperor, and apparently he used to limp. So after this, people started calling limping claudication. Now when we say claudication, we actually mean the pain caused by the accumulation of lactic acid as a result of anaerobic metabolism, as a result of ischemia to the limb muscle. But now I've stopped for a while, and even though the blood supply to my leg is limited, it's caught up again. And fresh oxygenated blood has reached the relatively hypoxic muscle. The fresh oxygenated blood has oxidized the lactic acid. In other words, my muscle was metabolizing and accumulating an oxygen debt. Now, the blood supply over a period of time has paid that oxygen debt back. That means the pain in my calf muscle has now gone because the lactic acid has now been removed. So I can now start walking again. The only question is, of course, how far can I walk before I get the pain again, before the muscle runs out of oxygen? Because when that happens, I'll get the pain again, I'll start limping, and I'll have to stop. I've got an intermittent ischemic pain on exercise. I've got intermittent claudication. Well, I hope that chap made it home. Now, let's go on and think about another group of clinical features, reduced peripheral pulses. Now, can you see that if the lumen of the arteries is narrowed, less blood is going to get through, so the pulses will not feel as full? A full pulse, remember, feels full and bounding. But if the vessel is atheromatous, then less blood will get through and the pulses will feel weak. Indeed, they could even be absent altogether. So an important clinical feature and an important part of patient assessment, reduced peripheral pulses. And the pulses we're thinking about here, well, firstly there's the femoral. Further down the leg there's the popliteal. Further down still at the ankle there's the posterior tibial. And then on the foot there's the dorsalis pedis. Now these are the 4 main pulses in the leg that it's useful to learn to palpate. Of course, the way to learn to palpate the pulses in patients with diseased legs is to practice by palpating the pulses in people with healthy legs. So let's now have a look at some of these pulses, looking at their positions. What I'm doing now is I'm palpating the dorsalis pedis pulse. This is the dorsal surface of the foot. Pedis refers to foot. And what is useful when you're palpating pulses is to press fairly hard with your fingers. And to do that it's useful if you have some opposing pressure. So in this case I'm pressing on the bottom surface of the foot, and there I can feel the dorsalis pedis pulse quite clearly. Now the next pulse I want to look at is the posterior tibial pulse, the posterior tibial artery, and this is normally palpable just behind the medial malleolus. So I'm going to just feel in there. Oh yeah, I can feel that really clearly now. And I've got opposing pressure again with my thumb on the other side of the patient's ankle. In fact, if you look really closely there, you might be able to see my fingers move. That is such a good pulse. It feels full and bounding. That's good because this is a perfectly healthy leg, and it's good to practice on healthy legs because when you come to feel the pathological one, it's much easier to tell the difference. So the pulse here feels regular, it feels full and bounding, which is quite normal. And this isn't surprising because we can see this foot feels reasonably warm, the colour's good, there's hairs on the toes. It's generally a well perfused limb. No pathology detected here at all. We can see the same on the other side. This foot feels fairly warm, the colour's good, there's hairs here. And I don't know if you can get in to see this, but when I press on that there, the colour comes back fairly quickly. And again on the toe here, if I press on that, the colour comes back fairly quickly. A good capillary refill, indicating that the pressure of the blood in the arteries supplying these toes is quite adequate. So far I'm quite happy with this limb, with the dorsalis pedis and the posterior tibial pulses. Now working up the leg, the next one I want to feel is the popliteal artery. Now the popliteal artery is in this gap in the back of the leg behind the knee, in the popliteal fossa. Now the popliteal artery is quite deep in the popliteal fossa, so I'm going to have to press fairly hard to feel this. So again I'm going to use opposing pressure with this thumb. I've actually lined my fingers up like this so I can feel the line of the artery. Fairly deep pressure there. Yeah, and I can actually feel the popliteal pulse there. This one's harder to feel, but to press fairly hard. Yeah, so fairly deep, firm pressure, and I can now clearly feel the popliteal pulse. And again, this feels full and bounding. And it's not surprising because again, this area of the limb looks quite healthy. The hairs, there's plenty of hair on it, it's a good colour, and it feels nice and warm. So again, I'm very happy with that limb at the moment. Now the next pulse I want to examine, going further up, is the femoral artery. Just feeling for the front of the pelvis there. And normally you can feel the femoral artery here. So if the patient's a little fat, it's good to push the excess abdominal tissue out of the way, but this patient isn't obese, I'm pleased to say. Yep, and there we have the femoral artery. Quite a big artery. If you get your fingers well positioned, normally you can feel this one quite clearly. So again, with all these pulses, it's a question of practicing the position, preferably on healthy individuals, getting the feel of the pulses on healthy individuals, and then when you feel the pathological pulse, it's usually fairly obvious. Now another clinical feature with ischemic legs is pain. Ischemia gives rise to pain. And this is generally true whenever you get ischemia. It's normally associated with pain. There are exceptions, but very often it's associated with pain. And the pain is often worse at night. This is one of the characteristic features of ischemic leg pain, that it's worse at night. Now, can you think why the pain might be worse at night than through the day? Well, one reason is fairly obvious. Through the day, patients are normally standing up, maybe moving around, or at least sitting. And that means the feet are low, and there is a gravity assist in the perfusion of the lower part of the limb. The blood is literally going downhill to perfuse the feet. That means that the degree of ischemia is reduced, therefore there's less pain. Then when the patient goes to bed and is lying flat at night, well, they lose that gravity assist. Incidentally, if you put the patient's legs up, if you lie the patient down and lift the leg up, very often the pain becomes worse really quite quickly. That's another classic clinical feature in ischemic leg disease. But there's another reason the pain gets worse at night. Less obvious perhaps, but when you go to sleep, your blood pressure normally drops. Your systemic blood pressure is lower when you're asleep than when you're awake. That means the perfusion pressure is going to be reduced and ischemia can be exacerbated. The ischemia will get worse, therefore the pain will get worse. So what the patients often do, if it's the right leg that's affected, they'll sleep on the right side of the bed and they'll hang their leg out over the edge of the bed, so there is a gravity assist in the perfusion of the foot. If the pain is in the left leg, then they'll sleep on the left hand side of the bed and they'll hang their left leg out of the bed, again to gravity assist. If it's even more severe, sometimes these patients can't go to bed at all because of the pain, and they have to sleep actually sitting up in a chair, so they've got gravity assisting the perfusion all the time. So pain, quite a problematic feature in peripheral limb disease, very often worse at night. Now, loss of peripheral hair is another clinical feature. Hair, of course, grows from the hair roots, which need to be perfused with capillary blood from an arteriole. And if the perfusion pressures are reduced, there is less blood getting to the root, to the hair of the, if there's less blood getting to the root of the hair, then the hair is not going to grow effectively, and there'll be hair loss on the limb. And sometimes this starts in the toes and works up, and you can actually see a line on the leg where the foot and the lower part of the leg have gone bald and there's no hair on it. very often a sign of ischemic, peripheral ischemia. Shiny, thin skin is another possible feature. The skin becomes thinner because it hasn't got an adequate blood supply, therefore it can't nourish its tissues very well. And thin skin often seems to become shiny as well. So shiny, thin skin, another feature of peripheral ischemia. In addition to this, there can be discoloration of the periphery. So the feet and the lower part of the legs, normally starting at the feet and the toes, can be discoloured. And this discoloration can vary. For example, in the acute limb ischemia, the limb can go white all of a sudden and later it will become mottled. In the more chronic limb ischemia, the limb can be pale and sometimes cyanosed, and eventually, of course, if the tissues start to die, necrotic gangrene, which is black. So pay attention to the colour of the skin. Another fairly obvious feature, if you think about it, is if there's not enough warm blood getting through to the limb, it's going to start feeling cold. Now, or even ordinary feet, of course, can feel cold on cold days, but the limb is disproportionately cold when you feel it with your hands. So a disproportionately cold limb, another possible clinical feature of the ischemic limb disease. Another feature that sometimes occurs is peripheral neuropathy. Now this is death of the peripheral nerves. This can be due to ischemia, and sometimes in diabetes, as well as being due to ischemia, it's caused by the high blood sugar levels adversely affecting the nerves. But normally it's caused by ischemia in the small blood vessels, microvascular ischemia, causing peripheral neuropathy. This can present as pins and needles, numb sensations, pain, irritability, general neurological features in the leg. Ultimately, if it becomes very severe, it can result in loss of sensation from the leg altogether. And of course, it can affect the motor as well as the sensory nerves. So there can be motor loss in the leg as well. So peripheral neuropathy. Another feature is arterial ulceration.